Hey guys, it's Wilker Patrick, nursing educator inside the Coursera platform, and today we're going to go over heart failure and we're going to make it super simple and easy for you guys to understand. If you're watching this video, you're probably preparing for your cardiac exam in your med-surg class, but heart failure, you're going to see it in lots of different aspects, and it's especially common on the NCLEX. Now, in this video specifically, we're going to go over the pathophysiology, the signs and symptoms, the risk factors and complications, the treatment, and of course the nursing interventions associated with heart failure. If at any point you have further questions after this video, make sure you guys contact one of our nursing educators by texting us or go to tactilebr.com to contact us there. All right, so let's get right into it. Heart failure. So what is heart failure? Well, the name pretty much describes it. The heart fails. So what does that mean? What does the heart actually do? Well, of course, the heart is responsible to pump blood out to the body. But pumping includes specifically two things. It includes filling and then ejecting blood from the heart. So I want to go in deep detail about the pathophysiology because I'm a huge believer in if you understand the pathophysiology, all the other concepts that these nursing exams and NCLEX like to ask you is going to make sense, such as the signs and symptoms. They always reflect back on what the pathophysiology is. And then same so forth with risk factors and complications and the treatment. So let's deeply understand the pathophysiology so the rest of it just makes sense to you. Now, what's commonly talked about with heart failure is the difference between right-sided heart failure and left-sided heart failure. Well, the truth is that they're both actually two different conditions, but they're categorized under the heart failure because it includes the inability to eject or fill the heart. So when we understand pathophysiology, we need to understand these aspects. So right-sided heart failure would start with that. With right-sided heart failure, I want you guys to remember this. It starts with an R because it means the rest of the body. The rest of the body meaning the blood backs up from the heart to the body. So let's explain that. So we have right-sided heart failure, the right side of the heart, right? So we have our right atrium and our right ventricle that goes to what? That deoxygenated blood goes to the lungs, so that way the lungs can go ahead and infuse oxygen into the blood to then go out to the rest of the body. Well, with right-sided heart failure, when we have a deficiency on that side, where does the blood come from? Well, the blood comes from the rest of the body. So when the ventricle fails, so the right ventricle, that means the blood is not going to be able to be ejected efficiently into the lungs. So what happens? It gets backed up. So your bodies are actually very similar to plumbing systems. So what happens if your sink gets clogged up? Well, that water is going to back up into the sink, right? And that level of water is going to rise. Think of it no different with our heart and our cardiovascular system. Our vascular system is consistent of pipes that propel blood back up to the heart so that way it can go recirculate with oxygen. But when that right ventricle fails, the water levels rise and it backs up into our vascular system, which is the rest of our body. So a key term that the nursing exams and the NCLEX like to use is calling it systemic edema. Systemic meaning the body. All right, so let's get into left-sided heart failure. So the pathophysiology of left-sided heart failure is the same, but it's the location that is different. So when we say left-sided heart failure, that is the left ventricle. So we need to understand how blood goes through the circulation. Where does the blood come from that goes to the left ventricle? Well, it comes from the left atrium, which gets blood from what? The lungs. So when I want you to remember with left-sided heart failure, it starts with L. So L means lungs. Hey guys, it's Wilker Patrick, nursing educator inside Coursera. I wanted to let you guys know that I will help you with anything you need at any time if you just send me a text at 940-218-4062, 940-218-4062. Let's get back to the video. So left-sided heart failure means lungs. It comes from the lungs. So we use the analogy with the pumping system. So what do you think would happen if that left ventricle fails to pump blood out to the rest of the body, right? So that aorta. So if it doesn't do that well, the blood's going to back up and of course rise, right? Where is it going to rise back up into? The lungs. So as you guys can assume, our lungs don't work very well when there's a bunch of fluid in them, right? So when there's a bunch of fluid, we're literally drowning from the inside. So let's circle around and explain the pathophysiology entirely. So when we have a left-sided heart failure, that is your left ventricle, which gets blood from the lungs. So left equals lungs. So that blood backs up into the lungs, and the lungs get increased fluid that stays in those lungs and it increases the pressure. What happens when there is increased pressure in the lungs? What does it actually put pressure on? Well, where does the blood come from that goes to the lungs? Well, that blood comes from the right ventricle. Well, when there's increased pressure in those lungs, it's causing resistance for that right ventricle. Well, eventually, it could cause right-sided heart failure. So that's something I want you guys to write down, is that left-sided heart failure could actually cause right-sided heart failure. All right, so if you guys understand that pathophysiology, the rest of this stuff is going to be super easy for you to understand. All right, so let's go to signs and symptoms. So the signs and symptoms difference between right-sided heart failure and left-sided heart failure. So we go back to the right side. Where does the blood come from? The rest of the body. So we think, where does the blood back up to? The body. So these signs and symptoms are associated with systemic edema. Remember, again, key term there. What do you think we would see with systemic edema? We have jugular venous distension, which is also called JVD for short. Why do you think that we're going to have jugular venous distension? So that is that big, large vein that is on our neck, and when we have fluid overload or fluid backing up from the heart, then we're going to have distension. Why? Because the blood backs up, it's distending those veins, right? So that is the closest big vein that we'll see, and it's very obvious because it's on the neck. So there's not a whole lot of fat covering that vein. You're also going to have signs and symptoms such as ascites, which is abdominal swelling. So the fluid gets backed up and engorges that liver, because where does blood come from that goes up to the right atrium? That causes something called portal hypertension. And that portal hypertension increases the pressures in the liver, which allows fluid to leak out into the abdominal cavity, which is called ascites. And of course, as you can assume, since there's blood being distended and fluids leaking out of the abdomen, it's also going to cause something called hepatomegaly or splenomegaly, which is just liver enlargement or spleen enlargement. Another sign and symptom of right-sided heart failure is hypertension because of the distension and the backup of fluid in the vascular space. And then key term here, guys, pitting edema. So this is just peripheral edema, so the fluid backs up. You'll see it in the ankles or on the foot as a common location, but you want to remember pitting edema is associated with right-sided heart failure. All right, now going back to the left-sided heart failure. So you guys remember the pathophysiology? Left equals lungs. So you're going to see signs and symptoms that deal with the lungs. So what are the common signs and symptoms? We have shortness of breath, which fancy words, dyspnea or orthopnea, so increased shortness of breath with activity. But our main concern here is pulmonary edema, because pulmonary edema is defined by fluid retention in the lungs. What are those common signs and symptoms with that? That is pink, frothy sputum. That is a huge common concept with your nursing exams and NCLEX. And then you're going to hear crackles, which is associated with fluid retention in the lungs. Sometimes they use the word rales, and if you guys think rales is in the tails, that's in your lower lungs, because that's where the fluid would start collecting. And then of course, since there's fluid retention, it decreases the ability for our lungs to oxygenate and ventilate. So you're going to see hypoxia, and then because of that hypoxia, another sign and symptom is dizziness. Now, left-sided heart failure also causes hypertension, but the mechanism is a little different than right-sided heart failure. See, right-sided heart failure hypertension is related to fluid overload, because just simply the fluid spaces are getting distended because of backup of fluid in the rest of the body. But with left-sided heart failure, it's a little different. I want you guys to remember that left-sided heart failure, where does that blood go? That blood goes to the body to go give oxygen to those tissues that are in need. Well, what is our neediest organ in the body? The neediest organ in our body is the kidneys. The kidneys take 20% of our cardiac output. And there's a reason for that, because the kidneys have lots of compensation mechanisms that maintain a lot of different balances in our body. And one of those balances is, of course, blood pressure. So the kidneys have something called the RAS system. It's the renin, angiotensin, aldosterone system. So we talked about how the kidneys are super needy, right? When there is any moment that the kidneys believe they're not getting enough blood volume or enough oxygenation, they stimulate something called the RAS system. Now, in the case of left-sided heart failure, the kidneys falsely think there's not enough blood volume in the system to get enough oxygenation and blood circulation. So what do they do to compensate? They stimulate the RAS system. So what specifically does the RAS system even do? Well, it does two things to our blood pressure. It stimulates aldosterone and stimulates angiotensin. Now, angiotensin is a major vasoconstrictor. So of course, when you constrict those veins, it's putting even more pressure on the heart, so even more resistance, which causes even worsening heart failure. With that more resistance, it's putting even more cardiac demand as well, so it's compromising the circulatory system. Now, what does aldosterone do? Aldosterone causes the kidneys to hold on to more water and sodium. So that puts even more pressure on the heart because it will increase the blood pressure, increase that vascular volume, and causes even worsening heart failure. And also, to make things worse, it causes potassium and bicarbonate to spill. So we're more likely to have hypokalemia, which causes what? Arrhythmias. And then also bicarbonate is an alkaline base for our body. When we lose that, we're at more risk for acidosis. So that transitions well into complications. So specifically with left-sided heart failure, we're worried about what? The lungs. So pulmonary edema is a complication of heart failure. Of course, hypoxia, also associated with left-sided heart failure. And then what did we just talk about with potassium, and what is it associated with? Arrhythmias, because of the low potassium, because aldosterone increases, and that causes water and sodium retention and the spilling of potassium and bicarbonate. Now, because we're losing bicarbonate, which is an alkaline base for our body, then we're at more risk for either respiratory acidosis or metabolic acidosis. So those are also complications that you'll need to write down. Now, with right-sided heart failure, we got to think of the right side or the rest of the body. Some complications you may see with right-sided heart failure is deep venous thrombosis. So embolisms. So something you never want to do with heart failure patients is massage their calves. Why? Because if you massage your calves, you could dislodge a clot that's sitting there and cause pulmonary embolisms. So you guys can see how the pathophysiology, the signs and symptoms, and the complications all play and tie to each other. Now let's talk about what even causes heart failure. So most commonly, heart failure is caused by heart damage. So what damages the heart? Coronary artery disease, hypertension, and of course, myocardial infarctions. So when damage happens to the heart muscle, it becomes deficient in actually pumping, so ejecting or filling with blood. So you most commonly see those as the risk factors. Now there's other risk factors, of course, such as smoking, and another one that the NCLEX and the nursing exams love to ask about is obstructive sleep apnea. Why specifically, you may ask, with those? Well, what happens with those is you're putting stress on the heart. So think anything that stresses the heart out in a long period of time, then that is a risk factor for heart failure. Now, specifically with the lungs, with right-sided heart failure, if there's increased pressures in that lung, so smoking with lung disease, of course, when you have chronic inflammation in those lungs, you're going to put a lot of pressure on the right side of the heart because that right side of the heart is trying to pump the blood to it. Well, when there's pressure against it, just like how you have increased hypertension against the left side of the heart, well, when there's lung disease, you have increased pressure against the right side of the heart. So that could cause right-sided heart failure. So that is why smoking and obstructive sleep apnea are associated. And that is part of why we call hypertension the silent killer, because over time you may not have any symptoms, but all this time you're putting so much pressure on your heart, and eventually you're going to have something called heart failure. Diagnostics. There is only one lab value that you need to remember with diagnostics, and that is BNP. BNP is a peptide that is released when the cardiac muscles or the cardiac chambers get stretched. Why do they get stretched? Because the increased amount of volume in our vascular system. So when there's fluid overload, those heart chambers get stretched out, and that releases BNP. So this is a direct measure of how bad the fluid overload is. So anything over 100 is considered abnormal, so it's indicative of heart failure. Now remember this, anything over 900 is considered a severe heart failure. And then we also like to use echocardiograms, especially if we want to identify if it's a systolic heart failure. So any ejection issues coming from the left ventricle specifically, we look at with an echocardiogram. So remember this, guys, an ejection fraction below 40% is considered heart failure. All right, so let's go over treatment. So what do we want to do for patients with heart failure? What are the issues? Well, the issues is fluid overload, lung compromise, deficient pumping of the heart, the resistance against the heart, so blood pressure, and then of course, preventing those complications such as thromboembolism. So with heart failure, guys, the nursing exams and the NCLEX love to use prioritization. So I want you guys to remember ABCs. They put a lot of prioritization questions that reflect on heart failure. So what do you think is the number one priority? Of course, airway. Airway is the number one priority. Now, heart failure is not necessarily associated with any airway compromising. So the next one would be breathing. So I want you guys to think the left side, so left side heart failure, which equals what? Lungs, because they both start with L, is more severe than right side heart failure because of what compromises the lungs, which is breathing. Now, what's our number one concern when we go back to the pathophysiology? Well, it's the fluid buildup that sits in those lungs, which decreases the ventilation of those lungs. So the number one priority for treatment, guys, is to get rid of that fluid. How do we do that? It's through diuresis, which in turn is diuretics. Now, we specifically use loop diuretics for heart failure because it's most effective to get rid of that fluid in a quick amount of time. So this common suffix is IDE, so ide, so furosemide, other in turn called Lasix, or bumetamide, or other called Bumex. Make sure you guys remember when you give diuretics, you need to watch for hypokalemia because it spills potassium. Another thing, when you're giving IV push furosemide, you want to make sure that you push it slow. because it can cause something called ototoxicity. And it can also decrease the blood pressure too rapidly, so make sure you guys give furosemide slow IV push. That is a common concept as well on your nursing exams and the NCLEX. Alright, so we talked about how diuretics are the #1 priority. Why? Because it could back up into the lungs, which causes what? A breathing issue. Our next priority is circulation. So what helps improve circulation? Well, in heart failure, we have the inability to eject or fill the heart correctly. So with ejection specifically, we need something called an inotrope. An inotropic drug helps increase the cardiac contraction to improve the efficiency, to improve the contraction of the heart pump. So in result, our cardiac output increases, which is exactly what we want. Now, a common medication that is tested about on the nursing exams and the NCLEX is digoxin. Now, digoxin is not even trying to hide from you guys. It's a toxin because it literally rhymes with digoxin. Commonly asked about in your nursing exams and the NCLEX is asking about toxicity, and you need to know the signs and symptoms of digoxin toxicity. Most common, they ask you if you know about the bradycardia associated with it and also the vision changes or blurry vision. And then what is commonly referred to as, write this down, is green, yellow halos when you look at the lights. Digoxin toxicity is considered over a level of 2. Now also when you give digoxin, you want to make sure you listen to the apical impulse for a full 60 seconds. Make sure you guys write that down. And you never want to give digoxin with a heart rate below 60 because it starts getting a little risky there. Last thing about digoxin, guys, is that if there is a hypokalemia, so a low potassium below 3.5, you're more at risk for digoxin toxicity, so make sure you guys write that down. A lot of times I like to see if you know about that association. All right, guys, so we talked about diuretics and inotropes. So next we're going to talk about the next best thing is decreasing the resistance against the heart. So how do we do that? Is by decreasing the blood pressure, which is antihypertensives. Now our most preferred antihypertensives for heart failure is ACE inhibitors and angiotensin receptor blockers, so ARBs for short. Now if you guys remember, we talked about the RAS system, and that is specifically why we like to use these because they act specifically inside the RAS system. Now other hypertensives such as beta blockers and calcium channel blockers we typically like to avoid, but we'll get into that later. So what does ACE inhibitor even stand for? ACE inhibitor stands for angiotensin converting enzyme inhibitor. All right, so what that does is it actually inhibits the action of angiotensin 1 turning into angiotensin 2. This is the most preferred because it hits earliest into that RAS system. How we talked about RAS is the renin angiotensin aldosterone system. Well, when we have a stimulation of that RAS system, it releases angiotensin 2, which is a potent vasoconstrictor, which what? Puts more resistance against the heart. So we want to give a medication that directly acts on that, which is a ACE inhibitor. Now, a common suffix with ACE inhibitors is pril, so P-R-I-L. So you make sure you guys write that down so that way you can identify those medications when they put it in your nursing scenario question. Now, with every time you talk about a medication, we as nurses need to know about the contraindications with it. Now, with both ACE inhibitors and ARBs, what do we need to look out for? Well, we need to look out for hyperkalemia because what does the RAS system do? Well, it spills potassium to make a compensation out of it. But when you have something that blocks the spilling of potassium, you can lead to a potassium buildup. So you want to know that this medication or medications, ACE inhibitors and ARBs, can both cause hyperkalemia. Now, ACE inhibitors can cause something called angioedema or something called the ACE cough. Angioedema is the swelling of the face, especially the tongue, which compromises what? The airway. And the ACE cough is another side effect or adverse effect that causes a chronic cough, and it's very bothersome to a lot of patients. Now, typically when we have patients with these signs and symptoms, we get rid of the ACE inhibitors and we put them on a ARB, so an angiotensin receptor blocker. Now, this acts later than the ACE inhibitors in the RAS system, but it still works efficiently to reduce the ability of angiotensin 2 to cause potent vasoconstriction against the heart. Your common suffix with ARBs is sartan, so S-A-R-T-A-N. So I'm telling you guys right now, you need to remember those medications and you need to remember those indications and contraindications for either one. Now, while we're talking about hyperkalemia as an adverse effect, now sometimes they like to give a diuretic that does not spill potassium, like the furosemide or the butanide. So they give something called spironolactone. This medication is a potassium-sparing diuretic, which the adverse effect is, of course, just like the ACE inhibitors and ARBs, it blocks the ability to remove potassium efficiently, so it could cause hyperkalemia. So that's something you guys want to write down. All right, guys, lastly with the treatment is prevention of venous thromboembolisms. So what we use is anticoagulants. Now, many times in the hospital setting, they'll use heparin unless they're already on something like a warfarin before, but a lot of the times they'll use heparin or a low molecular heparin, such as Lovenox. Now, Lovenox is just the trade name. You guys want to actually remember enoxaparin as the actual generic name, because that's what most of your nursing exams and the NCLEX like to use. But in turn, we give these to prevent thromboembolisms, which is more common with what? Right-sided heart failure. And we don't want to ever massage the legs because that could potentially cause a dislodgement of a clot that's there already and cause pulmonary embolism. What are the contraindications? Well, if it's an anticoagulant, they're at risk for what? Bleeding. So you're going to watch and monitor for bleeding. All right, guys, so specifically nursing interventions, what do you need to know? You guys want to really pay attention to this, write this down, because a lot of your nursing exam questions are going to be over this as well. Diet is important because we want to make sure that we don't give them anything that could worsen the fluid overload. So what worsens fluid overload? Well, sodium. Sodium attracts water wherever it goes, and we definitely don't want to give more sodium, which could increase the blood pressure and then increase the resistance to the heart once again. So we want to encourage low sodium foods, so no processed foods, guys, and then also we want to do fluid restriction, and of course as prescribed. But most importantly, what reflects off of fluid restrictions is that we need to be strict on our intake and output. That is a key term. Strict intake and output is commonly seen in your nursing exams and the NCLEX. And also, guys, correlated with that, you need to do daily, once again, daily weights. That means not weekly. They like to try to trick you with that. It needs to be daily weights. And write these numbers down, guys. Anytime there is an increase of weight over 3 pounds in a single day or 5 pounds in a single week, that is considered a heart failure exacerbation. Now, if you guys remember, we talked about how priority is a heavy concept, reflecting back on these concepts for heart failure. So what that means is you need to get really strong in understanding your ABCs that reflect directly with heart failure. Once again, our main concern is breathing. Since airway is not really a compromise with heart failure, we want to be concerned about breathing as our main priority. So what do we do to increase ventilation? Because that's going to help with the breathing. We want to elevate the head of the bed, semi-Fowler's to Fowler's position, and then oxygen supplementation is typically used, especially if it's left-sided heart failure. What else increases the ventilation? Well, we want to do incentive spirometry, we want to do coughing and deep breathing, and of course, activity is tolerated to make sure they continue moving, because the more sedentary they are, the more likely that blood is going to back up into the lung. So how we talked about elevating the head of the bed, we also want to elevate the legs, because that also promotes blood to return back to the heart instead of getting pitting edema. Now, compression stockings can be used, but you just want to watch with caution, and especially with those DVTs. Another adverse effect you need to look out for when you give a blood pressure medication is, of course, monitoring the blood pressure itself. So if you have a patient that has a blood pressure that's less than 100 systolic, then you don't want to give the medication. So make sure you guys know those magic numbers. You don't give digoxin if the heart rate's below 60, and you don't give it antihypertensive if the blood pressure is below 100 systolically. Now, we briefly mentioned beta blockers and calcium channel blockers and why they're not typically good for heart failure patients. Now, this doesn't mean you won't see them with heart failure patients, but beta blockers and calcium channel blockers aren't as specific on the pathophysiology of treating heart failure. Now, in fact, it may actually cause some more issues if you give beta blockers and calcium channel blockers, and here's why. Beta blockers and calcium channel blockers are negative chronotropics. So what is chrono? It is the rate of your heart. Now, if you guys remember, cardiac output is the stroke volume with each pump, and then also the heart rate. So stroke volume times heart rate. When you decrease the heart rate, you're decreasing the cardiac output. And that's already an issue with heart failure patients. And that is why we give digoxin to increase the stroke volume, because we're increasing the power of that contraction. So in turn, we don't want to give something that's going to reduce the heart rate, which decreases the cardiac output. So beta blockers end with LOL, and calcium channel blockers end with PINE. So make sure you guys are able to identify those and know the pathophysiology associated with it and why we typically try to avoid them. Just know that ACE inhibitors and ARBs are our first choice for reducing that blood pressure. All right, guys, that sums up the major concepts for heart failure. I hope this video was helpful for you guys. Once again, if you have any further questions, feel free to contact us on our website on tactilevr.com. We would be more than happy to help you. Thank you guys for watching, and we'll see you in the next video. Hey guys, first of all, thank you so much for watching the video entirely through. It makes our day if we know that nursing school got a little bit easier after watching one of our videos. If you guys like this video, make sure you like it, subscribe to the channel for more, and drop down in the comments for any more ideas that you need help with nursing school. If you want to contact me personally, it's 940-218-4062. Thank you guys for watching. We'll see you in the next video.